Hi, everybody. Can you hear me okay? I was about to say good morning, and then I was about to say good afternoon. So good noon, everybody. Welcome. If you're in the room and you haven't gotten lunch, lunch is over there. If you're not in the room, I know we have at least 100 people more online joining us. We hope you have lunch or the equivalent wherever you are. My name is Susanna Baruch, and I'm the Executive Director of the Petrie-Flom Center for Health Law Policy, Biotechnology, and Bioethics here at Harvard Law School. And I have the privilege of just welcoming you today to this important conversation. We're going to leave time for questions at the end. We'll have questions in the room, and if you are on the webinar, please share your questions with us using the Q&A function. We have chat muted for today. Today's discussion toward a more effective, equitable pandemic response is sponsored by the Global Health and Rights Project at Petrie-Flom. I think it's fair to say that COVID-19 put a spotlight on many societal fractures during the course of its still with us in many ways course. And in the framework for global governance of health, it has to be of some comfort to all of us that the experts are studying in depth how to do better in the future. My own hope for today is to leave both better informed and perhaps with some optimism. I want to thank Laura Chong and Chloe Reichel at Petrie-Flom for making today possible. But my main job is to introduce my colleague and friend, Alicia Eli Yamin, who is a lecturer on law and the Senior Fellow on Global Rights and Health at the Petrie-Flom Center. She is also an adjunct senior lecturer on health policy and management at the Harvard T.H. Chan School of Public Health and senior advisor on human rights and health policy at the Global Health Justice Organization Partners in Health. You can check out the rest of her very impressive and lengthy bio on our website, but I will say Professor Yamin is known around the world for her cross-disciplinary work in global health, reproductive justice, and is deeply respected in both academic and advocacy circles. So with that, I'm delighted to hand it over to her. Thank you.
Thank you so much for that introduction, Susanna. And before I introduce our esteemed panel, I also want to thank the Petrie-Flom Center, my colleagues, Susanna Baruch, as well as Chloe Reichel and Laura Chong, and the faculty director, Glenn Cohen, for organizing this. I really think that this event, So pandemics and global health law go through cycles of crisis and complacency. And despite the fact that you would think that we would all have on our minds what happened during COVID-19, we seem to have again be slipping into the cycle of complacency, which manifests itself in various ways. The way in this country, we seem to have forgotten problems with supply chains and data management and information, as well as other issues in our fragmented healthcare system. But it manifests itself globally as well. The 2/3 of the world is submerged in debt, which prevents the building of resilient health systems. We seem to have forgotten the massive violations of human rights during the pandemic and as Susanna alluded to, the fractures in societies and between countries, the real loss of trust between North and South over things like the failed TRIPS waiver at the WTO. So this is an event about why all of us should care about this issue of a future pandemic accord, and can international lawmaking actually provide a more equitable, effective response in the next pandemic, which we know there will be. So we're really, really fortunate today to have 3 experts with different perspectives. Our main speaker is Gianluca Burchi, who is an adjunct professor of international law at the Graduate Institute of International and Development Studies in Geneva, and he's the former legal counsel for the World Health Organization, I've had the privilege of working with Gianluca for a number of years, and his grasp of the totality of what is happening in multiple spaces around these lawmaking exercises is extremely rare and impressive. Adam Kamrat Scott is the Dr. Jiang Yan Yang, visiting professor of global health security at the Harvard T.H. Chan School of Public Health, and is well known around the world for his work on global health security. He also worked at the WHO at some point.
Volunteered with them, yes. Personally.
And Ann Moeller is my colleague at Partners in Health, who I'm delighted to welcome here. She is the program manager on pandemic preparedness and response at PIH. So without further ado, so just to give you a run of show, Gianluca is going to talk for about 20 minutes. Then we're going to have a moderated conversation on the panel and then open up to you. So if you're thinking of questions, please, if you're in the room, you can share them later. And if you're online, please start sharing them in the Q&A function.
Off I go. Thank you, Ali. It's good to be here. I've been wanting to come to Harvard for a long time, so finally I managed. And Alicia raised a lot of expectations. I hope I won't disappoint you, because as you will see, what's going on is still very much a work in progress. The negotiations are underway. Failure is not an option, but it's a possibility. So what I'm going to do in 15-20 minutes is I put together a number of slides that I hope give a bit of a snapshot, high-profile snapshot on some of the issue that I think should be dealt with, and that COVID, like Alicia said, has revealed, or has confirmed actually, and how that translates in what is going on in Geneva, the politics of the negotiation. I don't see very well my slides, but yeah. It's, which one is? The arrow, yeah. But it doesn't move. Okay, so then next, please. Okay, so if you zoom out and go back to the next 3 years, what is COVID-19 shown or revealed or confirmed in governance terms, in legal terms? To me, there's a number of fundamental points. The first, and I sort of twist my neck in looking at the slide, is governance. Everybody says governance failure, nationally and internationally. So there's clearly a need to improve governance at various levels, to not only to respond, but most importantly to prevent a repeat of the disaster we had with COVID. Obviously, a crisis is always a good opportunity to create new institutions, and that's sometimes a question of power. So the question is also, is WHO the right institution? What do we need more? How do we strengthen what we have? And as you can imagine, that's already a pretty big debate. The second is power and control. During COVID, and even now, I think that smaller clubs like the G7, the G20, European Union, African Union, have called the shots more in political terms than the United Nations or WHO. So there has been, in my view, a bit of a concentration of power in organizations that can be very effective, but not necessarily representative of the whole world. I mean, the whole financing debate has been incubated by the G20, not by the World Bank, and that speaks volumes. The important thing, I think, some organization like the African Union has really taken a leadership role. The message about we need to manufacture our own medicine, we can't be reliant on international charity, has got a lot of hold and become a bit of a global message, not just for Africa, but it's a claim by the Global South. The third is financing. All the things we are talking about cost money and will cost money. And some people say the ODA, the official development assistance, is drying up, basically. And Ukraine has sucked a lot of money. So there's really a debate out there how we can generate enough money to fund pandemic prevention and control. What is pandemic prevention and control? Who is supposed to fund? To fund what? And so it's a big debate going on. As I said, it's very much a work in progress. Then the question of equity and solidarity. There has been a major victim of the pandemic. I don't think I need to tell you more about it, both nationally and internationally, and it's looming very large at the center of the negotiation. In particular, the demand from the global south. We cannot go through another situation where you vaccinate your people 5 times and we have 10% of what we need. And we pay market prices, where South Africa paid more than the European Union. It's grotesque. And finally, public and private authority. So in a way, COVID has brought the state back to the center. You remember all the scholarship about sovereignty. Sovereignty is something obsolete, is something so 20th century, the world is globalized. But during a crisis, we look to a public authority to protect us. But at the same time, who has really dominated our lives has been big pharmaceutical companies. Obviously, in particular in the vaccine area, because there's always inbuilt shortage. So basically, they print their own money. And so a question of balance of power between the public and the private sector looms very large. Then finally, as Alicia said, human rights has been one of the main victims of COVID from all point of view, in sacrificing our personal freedoms to all the disaster in terms of closures of school, loss of jobs. You don't have access to a hospital because it's all about COVID. So, and it's kind of alarming how that argument is totally outside of the negotiations in WHO. Human rights is totally absent from the current negotiations. So we can, have our own opinion, but it's a bit alarming. And then finally, and that takes me to the next slides, please, Laura, the question of legal rules. So a sense of we need international rules, shared rules to channel the politics, to make sure we have the right commitments, that we have an agreed basis for coordination. And what is the law that we have on the shelf? Because again, the crisis is a good moment to say we need new rules, new rules, new rules, because there's a lot of political pressure. But what are the rules that we have now available? Aren't they enough? Don't they cover enough? Why don't we even need a new pandemic treaty? And the main law that we have available specifically on protecting us from pandemics and other disease outbreaks, of course, is the international health regulations. I don't know if you're familiar with them. You will certainly have heard about them during COVID or even before. That's part of what WHO was doing and so on. I don't want to take too much time about that, but they're an interesting instrument because they're not a treaty. They're more like a Security Council resolution, if you want, legally binding, but they're not a contract that states ratify and sign. They are adopted by the Health Assembly, so all the member states of WHO, but then they enter into force automatically for everybody unless you opt out. There are many reasons for that, but one of the obvious rationale is if you want to protect yourself from a pandemic, everybody should be under the same rules. You cannot have big outliers that somehow weaken the chain. And so the regulations have long history. They were totally overhauled in 2005. I was part of this, when I was in WHO, the secretariat team that worked on the revision. So I have a bit of a bias in favor of the regulations. They've been criticized a lot, but I think they reflect the globalization of risk in the 21st century. You don't know where the next shock will come. And so the best thing you can have is a bit of an open framework where WHO and states are supposed to work together to try to, at the very least, to detect and contain what may happen. And so, and also it's a very political instrument because it may apply even to an act of bioterrorism if it spreads disease internationally, or an industrial accident. If Chernobyl happened tomorrow, the health effects would fall under the international health regulation. So it's pretty complex and pretty broad as a scope. And so the WHO has remarkable amount of authority under the regulations. If you study international organizations, you know very well that they're not the superpowers. They are sort of relatively weak instruments to cooperate, to try to create a forum for states and so on and so forth. And the regulations give quite a bit of authority to the secretariat, and that politically shouldn't be taken for granted. These are unelected secretariat that can declare an emergency, they can make recommendations that are not legally binding, but they cannot be ignored. They carry political weight. You can judge states by whether or not they follow these recommendations and so on. So that's the law we have on the shelf, narrowly focused on at least detect and contain international outbreaks of disease. They're being criticized for states not really following them, low level of compliance. WHO has this authority on paper, but then not really power. Dr. Tedros, I think, damaged himself by flying to Beijing and having a photo op with President Xi Jinping before he declared the COVID emergency. So the number of things that have prompted some criticism of the IHR. Could you put the next slide, please? But if we look at something like COVID, COVID is a disease that kills people. So there's a health component. But if you zoom out again, the causes and the effect are really 360 degrees, not even 180. So there's an element of complexity there that goes way beyond health. Because in a way, just where the pathogen comes from, if it was not a laboratory accident in Wuhan, it's part of the zoonotic problem, or the fact that more and more diseases jump from animals to humans, and sometimes back. And also the effect on human rights, on indebtedness of states, on supply chains, on transport. All of a sudden, flights were grounded, trucks were stopped at the border with maybe vegetables rotting because they couldn't get in. So if you want to look at the law that has a meaning to try to prevent and equip us better for the next shock, we need to look beyond just the strict health field. And we need to look, for example, at environmental law, at the drivers that push animal and humans together, that generate this zoonotic risk. So the climate change convention, desertification, and so on. And also, obviously, economic law. Alicia mentioned that the failure of WTO to agree on a waiver of patents for the COVID vaccine. So you see the crucial importance of the management of intellectual property law and economic law in general to try to improve the possibilities to respond to this event. I don't think that a patent waiver in isolation would have solved the problem. I would have been definitely a step in the right direction. So this is not, strictly speaking, health law, but obviously it contributes to a legal ecosystem on the prevention and response to this event. Human rights, I mentioned, disaster law, and here when I speak about law, it's not just binding law. These are normative instruments that are not necessarily treaties, but they have an impact, they have a political weight, and so on. Disaster law, there's a famous Sendai disaster framework. There is like a coordination template from international organization to local authorities. And obviously something like COVID is clearly a disaster. So it fits into that mold, but you don't hear much about that. Then obviously financing, pharmaceuticals. Here we don't have much international law, but think of the practice of the industry, of the networks of contracts that sometimes we don't even know about. They are not disclosed, or they are disclosed, they are totally redacted. So you have these public procurement contracts where states maybe invest billions of dollars, and we don't really know much of what the strings are, the conditions are. So that's the element if you want to transnational law. The international element of what happens in the world that cannot be labeled as a treaty, but at the contractual level, at the soft law level, has a lot of importance. And so this big ecosystem should be taken into account. And obviously easier said than done, because even a government, I mean, this country as a big government where the various agencies have quite some problems coordinating and getting together. If you project that at the international level, it's easier said that the parties to the Biodiversity Convention need to work hand in hand with WTO. Yes, but you can see all the obstacles in terms of power, in terms of politics, in terms of interests that they represent. But from a rational point of view, I don't think you can ignore that you need to look really 180 degrees to see what are the rules that can protect us. Could you put the next slide, please? And so, no, too far. Yeah, no, up. There should be something about the, okay, down. Okay, yeah, no, down. Okay, okay. So here comes the pandemic treaty. That was initially a European initiative, pushed very much by the European Council. So that's a body representing the 27 member states. And I sort of was part of a number of meetings where that was presented. And it was interesting because it was a very bad marketing approach. Because basically the Europeans said, we have a huge governance failure, we need to fix it. The international health regulations are not enough, we saw it. So a treaty is a solution. But without explaining very well why the treaty is a solution, to do what? What is the minimum elements that the treaty should have? So in a way, many people saw it as a bit of an opportunistic move by the European Union to put themselves in a political space that was left a bit unoccupied by the toxic relation between the Trump administration and China. The Security Council was paralyzed for months. And so in a way, it was the obsession of the European Union. We are so minor player politically. So here we have possibility to really drive the action on something that is so important and so political. And so that's how it was born, and it got traction. The first to be converted was Dr. Tedros, the Director General of WHO. That really started walking around the world saying treaty, treaty, treaty. And that obviously puts the WHO Secretariat in a delicate position, because when states negotiate a treaty, Secretariat should support but not advocate. And here they have a boss that has been advocating. He's been quiet now, but at the beginning, he really pushed a lot in favor of the treaty as the legal tool of choice to fill that space and to do what the international health regulation could not do, but without necessarily linking it to the rest of the legal ecosystem that I showed you. At the same time, just to give you a little bit of a flavor of the complicated process going on. So the negotiation of the treaty started in early 2022. And there have been a succession of drafts, but frankly, it's still very much in the air. It's supposed to be adopted next year in May, so we are literally talking about 8-9 months. And countries sitting in Geneva, they haven't really started negotiating. They have not sunk the teeth in the text. We still have succession of drafts, a lot of posturing, a lot of positioning, but not really, roll the sleeves and starting negotiating. So on the one hand, a sense of emergency, of urgency, we need to finish by next year, we need to be prepared. On the other, this slow-moving thing, where states are dancing around each other, but not really getting very engaged in the text. At the same time, the United States, that was not, as you can imagine, a big friend of the idea of a new treaty, has launched the idea of, what about the international health regulation? Why don't we fix them? That's the law we have on the shelf. That's the law that we know may be flawed, but we can fix it. So they engineered the start of an amendment to the international health regulation. And so for a number of reasons, we have these two parallel processes, which is really dysfunctional, because the pandemic treaty and international health regulations being negotiated by the same states and with a number of overlapping proposals. So with this almost esoteric question, what topic goes in which instrument? And obviously that's a political choice. There's no metaphysical answer to this question. So there's a lot of fatigue in a way going on in Geneva. And the main point that I want to bring here is that we have two different narratives. And that becomes very clear after almost 2 years of negotiations. On the one hand, and I'm oversimplifying now, developed countries want security. They want to have the tools to prevent the next pandemic. So we are talking about what the WHO should be doing, giving alert, surveillance, preparedness of health systems, sharing pathogens to manufacture vaccine, and so on and so forth. The Global South, again, oversimplifying a little bit, wants equity. You see, we've been burned so badly by what happened during COVID that the absolute priority for us is avoid a repeat of that situation. So we want to not just to be at the end of the line in buying the vaccine, we want to manufacture the vaccine. So we want to have access to financing, to intellectual property. We want to be able to produce our own vaccine. We need training, a workforce, and so on and so forth. So there are two totally different lines of reasoning, because one is more how to stop the emergency. The other is more a systemic change. It's like almost changing the way the pharmaceutical industry works. So they're really going in parallel and being equally stubborn in we need to get a bottom line, otherwise there's no treaty. So the chances of a failure are not insignificant. Next slide, please. And I'm coming to the end. Okay, so this is in rough approximation, the proposed content, both for the pandemic treaty and for the IHR. As you can see, there's a lot of stuff there. So it's also complex to negotiate all these things together because some are more crisis-based, some are more systemic, like the question of equity. Just to speed up, could you put the next slide, please? So equity is a buzzword in Geneva, in particular from countries to the global south. But what does it mean? If you unpack it, it means a lot of things. It means, first of all, the developing countries push for this idea of common but differentiated responsibilities. And that is an echo of climate change law that didn't go very well. Equitable access to medical countermeasure, so to avoid the repeat of what we had until now, transfer of technology, intellectual property, so that's one of the big red lines, the possibility of having easy waiver of patents or even not patenting, have something in the public domain. And that's where the pharmaceutical industry is circling the bandwagon, because for them, that's the bottom line. And many developed countries saying, look, we are prepared to move out of the negotiation, but we have some economic bottom lines, and those are some of them. The question of financing, again, that looms very large, and countries in Geneva has not really started the discussion until now, but how to generate international financing, what to finance, and what does it mean to finance pandemic preparedness and response? Because that's basically financing health systems. You need solid health systems. So that's our crisis management. It's really going deeply into the management of public health services. And then finally, the question of pathogen and benefit sharing. That's a bit more technical and esoteric, but fundamentally the point that if you want to have vaccines, you need to have access to the pathogen, to the virus. But there's a lot of law, in particular biodiversity law, that attaches benefits to access. If I give you the pathogen, I want benefits in return. And that's a bit what developing countries, the global south, use as a leverage. We need guarantees of benefits, not just handouts, but systemic benefits to have a more balanced ecosystem in the future. So that's where we are. There's a concrete possibility of failure, frankly. Nobody wants to talk about failure. We are still living by the fiction, in my view, that the negotiations will finish next year. The American election looms very large because if, God forbid, we get a second Trump administration, the treaty is dead on its tracks, and maybe even international health regulation. So there's a lot of urgency to wrap things up before the end of next year. So yeah, I wish I could be more optimistic, but at least that's a bit of the state of the art of what is going on. So thank you for your attention.
So I guess I want to take up the challenge that you put out, Gianluca, and say, what if we do fail?
Yeah.
What if there is no pandemic accord by the World Health Assembly in May of 2024? Why should this matter to us?
Question for me?
Yes?
So in Geneva, we work quite a bit with the various diplomatic missions. And so sometimes over coffee, totally off the record, they are a bit more forthcoming than they can be on record. And some of them are saying, look, if push comes to shove, we can live without a pandemic treaty. We have the international health regulations that at least are the safety net that we know and that we've been operating for a number of years, where our health authorities and so on are familiar with. And we learned enough from COVID that we can have better safeguards even without the treaty. So in a way, it's not the absolute condition. And that is a bit scary, because that means that a number of countries are factoring in the possibility of moving out of the negotiation, of accepting failure or pushing the can down the road. But that's not a good, it's not a good message, because the message until now has been the opposite. We need something in place by next year, because the next pandemic will be around the corner. So that's a additional legal tool that we need. So it's a bit of mixed messages, I would say.
So let's take that as a starting point, Adam, and go to, Steve Solomon, who's a legal advisor at the WHO, has said at the World Health Summit in Berlin that, equity needs to be front and center. As Gianluca said, there are different narratives. And I guess my question to you is, what would it take to bring sort of the global north and the global south together to get across the finish line in May?
That's an easy one.
Yeah, that's the $1,000,000 question, really. As John Lucas said, like the challenge that we've got at the moment is a lot of posturing on either side of the debate. Now, in an attempt to sort of move past the impasse which currently exists, there are some drafting groups where they're trying to deal with some of these more tricky issues, and in particular around Article 12, which is dealing with benefits, access and benefit sharing, and also Article 11 in terms of technology transfer and things like that. So governments have sort of broken different parts of the current draft up into smaller drafting groups to try and progress consensus in that approach. Now that worked Jean-Luc was in the council seat in 2004-05. I was actually sitting with the Australian government on the other side. So I've seen those drafting groups firsthand, and they are very effective in actually progressing things. But inevitably, even when you have a drafting group, you may reach consensus in a drafting group, but then you have to bring it back to the floor. And that's where you can also see things start to get pulled apart and broken apart again as well. So it is going to be a very challenging time frame between now and May 2024. And I suspect that I'm a little bit more pessimistic than even Gianluca, in that based on the experience of the IHR Intergovernmental Negotiations back in 04-05, the idea that we'd be able to sort of square this in the next sort of 6-9 months is really quite the big ask for everybody. And my big concern, and I'll finish on this point, my big concern is that the speed with which these intergovernmental discussions are taking place, whereby you have basically hop skipping over pandemic accord discussions 1 week, international health regulations discussions the next week, and it's been fairly consistent like that since the process started, that you have a situation where a lot of low-income countries have not even necessarily fully engaged with the process yet, because the speed with which these discussions are happening is such whereby, it's difficult even for countries like Australia or the United States to stay on top of these negotiations, given all the intricacies that are involved. So that's also one of my concerns in terms of, like, what do we end up with at the end of this process, even if taking into account the potential for a Trump 2.0, what would be the instrument? What would it look like at the end of that process?
And are there red lines in your mind about, what an instrument should not look like? What would be worse than not coming up with agreement?
Well, I think, so again, just picking up on a comment that Jean-Luc made, the idea that you would end up with an instrument, I think it's not necessarily that there's red lines there that wouldn't be crossed. I think my bigger concern is that you would end up with an instrument being really pushed forward, but then if it's adopted under Article 21, which of the WHO Constitution, that removes this opt-out clause. Governments actually have to opt in, and that we could very well end up in a situation whereby, unlike the international health regulations where it's automatically binding on all member states under Article 19, you could end up in a situation where an instrument adopted under Article 21, and then you end up with high-income countries that turn around and say, well, that's fine, you've got your treaty, but we're not part of it. We're not going to sign and ratify it. And in that instance, I think that's a really bad outcome, particularly when we've got this platform negotiation process going on, and there's an attempt to kind of potentially exclude some things from the IHR negotiations to try and keep them in the pandemic instrument. But then if you end up with a pandemic instrument which doesn't deal with things like technology transfers and equitable benefit sharing, then you're not going to have the global south countries signing on. Vice versa, if it's too generous, you're not going to have probably global north countries signing on, and then whether or not those issues are being addressed by this other process with the IHR is the question. So,
Right. So, Anne, can I turn to you? And, so far we've been discussing this as, what is pathogen and benefit sharing? We've discussed the TRIPS waiver and intellectual property in reasonably, abstract conceptual terms of lines of negotiating instruments. But you have dealt with this on the ground for Partners in Health, and maybe you could tell us a little bit about what these equity claims actually mean for people in the real world who are embodied and suffered during the pandemic.
Sure. So I think an important lesson that we've learned as an organization in decades of responding to disease emergencies like HIV, tuberculosis, cholera, Ebola, malaria, Mpox, COVID-19 is how critical access to medical countermeasures is, such as tests, vaccines, treatments. And the reason access is especially critical for the populations who will ultimately be most impacted by a successful pandemic accord is that they don't live with strong health systems. And so when there is a disease event, just to use COVID-19 as an example, people don't necessarily have access to medical oxygen or to pulse oximeters to see if they require an escalation in care. They may lack essential medicines to treat other diseases that make them at high risk for COVID-19. And so, not only is access so important, but access can't be through donations from high-income countries and pharmaceutical countries. That simply hasn't worked. And I can give a couple examples from COVID. So with the COVID vaccines, there was a global collaboration called COVAX that was orchestrated to essentially receive donations of vaccines from rich countries and pharmaceutical companies, receive orders from low and middle income countries, and then serve as the mechanism to distribute them. But when there wasn't enough supply of the COVID vaccines, in part because the US and Western European countries ordered and paid for hundreds of millions of doses in advance and kind of locked up all of the supply. And then pharmaceutical companies had to meet that demand. And then during that especially deadly wave of COVID in India, there was an export ban on those vaccines. And so there wasn't supply to provide to low and middle income countries. And so while we were literally vaccinating children who were at very low risk of severe disease in the United States, we still had healthcare workers and people with chronic conditions who are at very high risk of mortality from COVID-19. They didn't have vaccines. And what ended up happening is countries would place orders, they wouldn't receive any sort of confirmation of what was coming and when. When they did receive shipments of vaccines, they were less than what had been ordered. Mixes of batches, which in the first series couldn't be mixed together, close to expiration date. That was
Sorry, just so in the beginning you had to take 2 Moderna or 2 yeah.
Thank you. And a lot of the doses were close to the expiration date and there was no notice given. And so countries would receive these doses. They didn't know what they were receiving. They didn't know when. They didn't know how much. And they had to act quickly because of the expiration date. And then they also had to move these doses from urban areas out into more rural, remote areas, which is where Partners in Health typically works. And the logistical challenges that were tremendous. I mean, because of the cold chain storage, training healthcare workers. And we saw in Massachusetts, we had this tremendous phased approach where we started with these mass vaccination sites and pharmacies. We realized people needed access to technology and transportation to get those. We started moving doses out into community health centers and then remote mobile clinics and then door to door. But that all took time and money and resources and planning. And in this strategy of just saying okay, people who have vaccines or who can make vaccines should just donate them at their whim, it doesn't work for the countries that are supposed to be the beneficiaries. And can I give one more example, or should we move
Sure.
on?
No,
Okay.
no, you can give another example.
And then using Paxlovid as another example, just thinking about COVID-19 still, it is manufactured by Pfizer. It is the most effective antiviral for treating people who are at high risk for COVID-19. And it is still not available to most individuals in low and middle income countries, and it's been available to us for almost 2 years. And so Pfizer reached an agreement to, through the medicine patent pool, to basically have a generic license available, but they restricted it to only 95 countries. And so middle income countries, which at the time were experiencing like 40% of the disease burden, couldn't afford to buy it. The countries that were covered by the generic license still don't have access. There have been so many delays. There's only been access through these like pilot programs. And there's this global health, or this health strategy called Test and Treat, which has been proven effective in so many disease responses, where you basically bring people in to be tested because you can offer them an effective treatment. You protect the individual, you protect the community because the person knows that they have the disease and so they don't spread it. And there's a surveillance component as well. But without a drug like Paxlovid available, you can't take advantage of that strategy too. And so I'm using those examples just to highlight that an opt-in strategy where, rich countries and pharmaceutical companies can say like we will distribute these really effective medical countermeasures when we're ready or when we have an excess, it simply hasn't worked.
So I think that's so important to understand why countries across the global south are saying we cannot go through, why there was such an erosion of trust, and why they're saying we cannot go through what you subjected us to during this pandemic. So I want to just, and how firmly those views are held, and how firmly embedded the pharmaceutical industry is in the global north countries that are negotiating now. There was just an article released today from the People's Vaccine Alliance that said shareholders of pharmaceutical companies and these executives had made $1 million every 5 minutes during the pandemic. While these barriers to basic access were going on. I want to pivot to a question about One Health, which you mentioned in your presentation, Gianluca. So both you and Adam have presented a rather pessimistic view with different nuances.
Mildly pessimistic.
So One Health, maybe in a word or two, if you could define One Health, but that is an extraordinarily ambitious agenda. And to think that One Health is going to be effectively incorporated into this instrument is a very ambitious aspiration. So One Health is this idea that links a lot of the different fields of health: animal health, planetary health, environmental health, human health, et cetera. So what would One Health in a pandemic accord look like? And why is it so important to link, say, climate change with health?
Well, fundamentally because by now we know that many of the infectious diseases that really cause problems come from animals, starting from HIV/AIDS. They came from chimpanzees, came from monkeys. By now seems scientifically clear that that was the case. Influenza comes from birds. Coronaviruses come from a variety of animals. So we know that zoonotic diseases are a big problem. Climate change, the change in environmental conditions is pushing animals and humans together. So it creates even more of a breeding ground for this. The globalization of the meat industry also, we forget about these horrible, huge animal farms where animals are pushed together, they are traumatized, sick animals, they breed the possibility of these viruses, plus the tons of antibiotics that we dump on healthy animals create the possibility for antimicrobial resistance, bugs that resist the antibiotics that we have. So we really have a bit of a disaster looming. And so the idea is, what can a treaty do realistically? Because here we have environmental drivers, that the condition that put animal and humans together, that in a way are regulated under environmental conventions and so on. So there is law on the shelves. If there is an outbreak of disease, there is law on the shelf. There is international health regulation. We have trade agreements, like the agreement on sanitary and phytosanitary services, that allow states to, for example, block the import of agricultural products when they are contaminated and so on. So we do have law. And that's something that we've been working on in Geneva. What is missing is law in the middle, what we call midstream prevention, which is basically, how do we regulate the space where humans and animals come together? And that can be the meat production farm, that can be the farms, but it can also be urban settings, can be indigenous communities that sometimes have this traditional way of feeding, where for example, Ebola in West Africa seemed to have started with a child eating a bat or something like this. So how do we regulate that space? Because that space is unregulated. And that would be, in my view, the priority for a pandemic agreement. And that obviously can do in many ways. You can ask countries to do particular surveillance. You can develop scientific standards that countries can use in their own surveillance, in their own response. So there are many possibilities. As you said, the challenge is the complexity, because that's where the human health community, animal health, environmental, food production. And that's why we have what we call in WHO the quadripartite, which sounds like a football team, but it's actually WHO, FAO, UNEP, and the Organization for Animal Health, that has established a joint program to try to bring together the complementary perspective. And I think that's very good news, because until now, One Health meant these agencies competing with each other, competing for funding, competing for political attention. Now the pressure is on, and they're really working together. They developed a joint action plan. So things are moving. And probably a treaty would have the benefit of solidifying this cooperation that for the moment is at a technical level. You can wonder, as you were saying, what is the value of a treaty on this? If, for example, the United States remains out, China remains out, Brazil remains out, some of the countries mega diverse, where the next big bucks can come from. So there is a very informal opinion in Geneva. Why not frame this part of the package, this part and the part about pathogen sharing, not as a treaty, but as a new separate regulation that in WHO's parlance, as I said before, would bind everybody at the same time? Frankly, that nobody dares to propose it, because it complicates things even more with 9 months to go with the putative date of adoption. But there is some rationale for having a scheme where everybody is party of, not just a treaty that slowly increments the number of parties and so on. So that's part of the most complex, but that to me is where a pandemic treaty or a pandemic instrument will make a difference. One Health, because there is a legal vacuum. There is legally an area that needs regulation, where we do need not just good technical work. We need a solid legal framework that a new regulation or a treaty can provide.
Adam, do you want to comment on One Health and
Yeah. So I'm very supportive of the idea that we need to consider much more closely the importance of One Health, right? And just to sort of, as Gianluca was saying, look, one of the challenges that we've got, we know from multiple disease events now that roughly about 70% of new infectious diseases to infect humans come from the animal world. And they end up resulting in a zoonotic spillover event, as what it's described. The challenge with that is that when we look around the world and the state of play with regards to animal health in particular, that the only countries that have historically tended to look at doing things like disease surveillance in animals tends to be those countries that export their animals for food. So there's 3 categories basically that you could sort of divide them, and there's different ways of describing them, but they basically come down to food animals, companion animals, and wildlife, right? So the only countries that tend to do disease surveillance is on food animals, and that's because it's directly related to trade. Otherwise, they don't really give a rat's about the health of animals. Then when you think about companion animals, we all love our dogs and cats, and I have my dog, she's still currently in Australia, but there's a little bit of surveillance around those. And then we come to wildlife. And this is where it becomes slightly more complicated as well, because you also have wildlife trade, which is believed to be part and parcel of some of the challenges with preventing these zoonotic spillover events. The big challenge, of course, when it comes to the pandemic treaty then, is that high-income countries want this because they see this as a key point of insecurity, right? So we need to address disease surveillance in animals, but to build that capacity around the world is going to take a huge amount of resources and a whole lot of new obligations on governments around core capacities, which a lot of probably global South countries will not be keen on. And in addition to that, at the end of the day, for global South countries, when things like wildlife trade are also intimately tied sometimes to food and protein in particular, then they're like, well, what benefit is it to us if we adopt these new core capacity requirements, right? Because you're putting more obligations on us to build these capacities, but it's not necessarily having any direct benefit to us. Sure, it might identify a disease outbreak before it starts to spread, but like there's a lot of work and resources that are going to have to go into that. So there's a whole lot of challenges that we're going to confront in that space. I mean, it is vitally important that we need to look at this more closely. And there's multiple studies that show, for instance, like, you know, how climate is adversely enabling mosquitoes and such to spread further and at both horizontally as well as vertically into sort of more mountainous communities. So populations are getting exposed to things like malaria that have never been exposed previously because of warming global temperatures. So the challenges are huge. And
So I'm super glad you mentioned that because, in my understanding of One Health, it's not just about zoonotic transmission. It's about vectors. It's about, I mean, it should be from a global health equity perspective about the food conglomerates and the food system that is quite pathogenic, the deforestation that is required to have huge herds of animals in that system, et cetera. So I wonder if you would, again, like kind of bring us down to what's going on at the ground level, Anne, in terms of how climate change has affected some of the operations at Partners in Health. And then there are questions already in the chat, and I would encourage you to think of questions here.
Sure. Yeah, I guess I could give two examples that I was thinking of listening to Adam speak. The first is not related to Partners in Health, but actually thinking about, but in an area that is close to where Partners in Health works, but thinking about how diseases move as a result of climate change. I was reading about the spread of Lassa fever outside of areas where it's endemic. Specifically, this one example in southeastern Nigeria, there are rats that carry Lassa fever, and the rats don't care for the increasingly high temperatures in the region or the flooding, and so they have been moving into new areas and spreading Lassa fever. And then I was also thinking about the recent dengue fever outbreak in Peru, and how, when you mentioned how mosquitoes move into new areas, the dengue fever outbreak actually impacted Lima most recently, and there hasn't been dengue in Lima before. It has been in the more rural parts of Peru. And what that means is like there's not a familiarity with the healthcare system or with individuals about new diseases, and that requires financing to provide training of healthcare workers, training of the population. But there's a symptom of dengue fever. It's referred to as a bone-breaking fever. And so people—
I've had it.
Oh, you
You
have
had
it?
It's terrible.
Wow.
And so what we experienced at Socios and Salud, Partners in Health Peru, is that the health system was overwhelmed by people in Lima who were experiencing this bone-breaking fever, but it's not a reason to go to the hospital. It's just part of having dengue. And in fact, there are other symptoms that would serve as a warning instead for when you need escalated care. And so then there's this overwhelming of health systems that are already kind of struggling to meet the needs of the population. And I think that that's something to consider. And then I'll just mention that Partners in Health in Malawi has been dealing with massive cholera outbreaks. And as the region is pummeled by more and more tropical storms and cyclones, most recently Cyclone Freddie in 2021, Cyclone Anna caused, or Tropical Storm Anna caused just tremendous destruction. But when people are displaced and access to clean water is disrupted because of these massive flooding events, there are cholera outbreaks too, and cholera can be very deadly. And going back to like the reliance of governments and pharmaceutical companies to make sure that we have the right medicines available for when different parts of the world needs them. There's only one manufacturer of a cholera vaccine, so there are 29 countries experiencing cholera outbreaks, and there's not enough of the cholera vaccine. And then we have like more and more cholera because of these climate events, flooding, displaced people, travel between impacted countries, and there's just not enough vaccine. And we saw this with Mpox too, you know, thinking about zoonotic spillover and how diseases impact different populations, where there simply wasn't enough of the Mpox vaccine for countries like Peru and Brazil that were experiencing outbreaks.
There is only one cholera vaccine manufacturer.
There is now only one. There were two, and one stopped manufacturing.
Incredible.
So I'm now going to turn to the questions from the audience, from the online audience. And again, I would encourage you to raise your hands or signal if you want to ask a question. So this is from Pedro Villarreal. And he says, concerning the pandemic accord, several provisions on research and development and access to medical countermeasures have been watered down with each subsequent draft. How do panelists assess the risk this poses for reaching consensus on equity, especially if the outcome of negotiations does not uphold key demands of mostly global South countries?
Well, that's obviously, it's the million-dollar question when you negotiate an agreement. What is the priority is to reach you tend to reach a minimum common denominator if you want to have an agreement, but that's obviously not satisfactory. So, I mean, that's the putative pandemic treaty is not an exception. There's so many agreements, including, for example, the Tobacco Control Convention. I was involved in the negotiation for the Secretariat, and you could see the level of ambition going down, to include in particular developed countries like the United States that in the end did not ratify. So that's the eternal question, whether you aim at something which is normatively stronger, but will get, by definition, by the get-go, fewer parties, or you aim at something that gets more traction. Unfortunately, and maybe I think Adam is right, probably, there's quite a bit of posturing, keeping the stakes very high, in particular from the Global South, that basically said equity is an absolute priority. If we don't get clear guarantee of better access to medicine and so on and so forth, we don't have an agreement. Is that posturing? We won't know until the end. So, you know, it's difficult to say at this stage, but there's also, a treaty is not the end, it's a beginning. When you have an agreement that has been adopted, in particular the agreement that tend to be fashionable today, a bit of a framework approach and so on and so forth, that's a starting point to build a normative framework, again, get stronger when the parties get together and they agree on more things. The Tobacco Convention, again, is a good example. So there are possibilities that are not so dramatic and black and white. We get something totally binding and solid, or we don't get an agreement. If there is a will to conclude a treaty where the two parties are prepared to compromise, that can be the beginning of something that can build over time. To be, personally, would be the most realistic outcome.
So I will just use my prerogative as moderator to interject. If I were negotiating on behalf of a global South country and I heard, oh, let's move this into a sort of conference on principles type framework moving forward, I'd say that's a recipe for broken promises.
Yeah, definitely.
So let me actually turn to Adam with this next question, which follows from this. This is from Uche Ngwaba in, I believe, in Uganda. Should we, because of the governance issues and all the financing issues, should we then be looking more closely at the idea of developing intermediate levels of health governance at the regional level, AU, Inter-American System, EU, where capacity can be developed to better respond to transnational health threats in the spirit of solidarity? Do you see merit in such an idea?
Yeah, I guess one of the pathways through this process potentially, and trying to get more consensus. One of the crux of the issue that we encountered with COVID-19, and for those of us that have been in the space for a while, we knew that there was going to be this problem around vaccines, right? Because we actually saw that back in 2009 with H1N1. Everyone has sort of somewhat forgotten about that, but that was also classified as a pandemic, and there was vaccine shortages at that point in time as well. So we knew that this was going to happen with COVID-19. I think one of the pathways forward, actually, which perhaps needs to be reflected in the accord, will be an emphasis on capacity building, and in particular, an emphasis around vaccine manufacturing capacity. And one of the propositions is having a whole series now of regional manufacturing hubs, right? Because the crux of the issue was supply shortages, right? Supply, demand, classic economic issue challenge. Well, if you want to overcome that, you need to address it by increasing your supply mechanism. Now, for me, one of the things that I'm watching really closely is how well the new vaccine manufacturing hub in South Africa is being taken up by African countries, because that sort of new manufacturing capacity, it's only sustainable if it has a market in non-crisis times, right? So when we're looking at vaccine manufacturing for all these other diseases that we're contending with, like yellow fever, like cholera and others, if countries in Africa are not putting in requests for vaccine manufacturing so that plant can keep manufacturing in non-crisis times, but then have the ability to convert to pandemic-specific manufacturing capacity in the times of a crisis, we're not going to succeed in this. So that would be one of my big sort of points that I would be certainly advocating to African governments as well. There's this new manufacturing capacity there. Let's support it. Let's get behind it. Use that as a mechanism. And then we can see that similar sort of manufacturing hubs being built in other parts of the world as well.
So we're actually over time, so we're going to have to end. If others in the room have more questions or comments, please just stay a few more minutes. But I want us all to join in thanking our esteemed panel, Gianluca, for the really incredibly concise bringing all of this together, and Adam and Anne to adding their perspectives. So thank you all for joining us online and in person.
Thank you.
Thank you, Alicia, for inviting us.
So fast. It goes so fast.